Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have a very exciting session with Dr. Isabel. Dr. Isabel, thank you so much for joining. And on that note, the floor is yours to take away.
Thank you so much for having me, and thanks for joining me tonight. I know for some of you guys it's pretty late, so thank you for your time. So I am currently a general practice resident, first year at Rancho Los Amigos National Rehabilitation Center in Downey, California. I went to undergrad at University of the Pacific in Stockton. I actually was in their 3-3 accelerated program, where we had 3 years of undergrad and then 3 years, if we were within contract, we can go. We had an interview at their dental school and we can continue on with the program if we chose to. I graduated in 2016 with a BS in Biological Sciences, but since I am from LA, I wanted to come back home since I felt like where we decide to go to dental school is where you form most of your dental connections. So I attended USC, Herman Osher School of Dentistry. I graduated last May. And at USC, I was in anesthesia selective and our co-team. I was involved in the special patients clinic, community health clinics, and mobile clinics. And that just really opened my eyes up to a lot of the underserved. And I felt like that was an avenue that I would really like to explore more of. And that is why I applied to general practice residency, and I will be graduating in a month. So what is a general practice residency? A general practice residency is a 1 to 2 year postdoc program for advanced clinical and postdidactic training in general dentistry in a hospital setting. There is also the AEGD, or Advanced Education in General Dentistry, which is also a 1 year program. That AEGs are usually more clinic-based and associated with a dental school. With the GPR, patients are generally more medically compromised. So these are patients that can't really be seen in a normal dental clinic setting, just due to all their medical conditions. So at Rancho Los Amigos, we actually specialize in special care dentistry. So a lot of our patients have a lot of physical, medical, developmental, or even cognitive conditions, namely autism, Down syndrome, spinal cord injuries, epilepsy, cerebral palsy, cancer, etc. As part of a GPR, we are required to fulfill 3 rotations, 2 weeks each, in anesthesiology, internal medicine, and trauma. We're also required to become certified in advanced cardiac life support, or ACLS, which is basically a step above basic life support, or CPR. And this is for administration of life-saving drugs in a hospital setting. So why should you and why did I choose to complete a GPR? So completing GPR, I felt like I could build upon the fundamental skills that I had learned in dental school. You can also pick up speed. And it's also a time to really decide on what kind of specialty you want to go into, especially if you're not sure, because it's essentially a gap year. You know, it's a lot of fun. You get to meet a lot of new people. You always have attendings there to bail you out if you ever needed it. We don't have any start checks like we do in dental school. So basically, we treat these patients as if we are in our own private practice. We review their medical histories and medications, and we just, start treatment. We only ask for help if, we're not comfortable with the certain procedure, or if you have any questions. Another reason why I wanted to do a GPR is because in California specifically, to obtain licensure, you do not have to necessarily take REB or ADEX. You can complete 1 year of a postdoc program. So either a GPR or an AEGD in California, besides taking REB, ADEX, or completing a GPR or AEGD, you can also obtain licensure through portfolio. After GPR, you can also obtain hospital privileges since we are being trained in a hospital setting. So what this means is our patients, a lot of the time, that are more uncooperative and cannot allow us to do dental treatment in the dental chair, we'll take them to the OR and complete dental treatment under general anesthesia. So hospital privileges just mean in the future, if you want to take your own patients who cannot cooperate or tolerate extensive dental treatment, you can take them to the OR at the hospital and complete treatment there yourself. Another great reason to do a GPR is just to bridge the gap between medicine and dentistry. A lot of our population is aging, and with aging comes with a lot more medical conditions that we have to worry about, and a lot of medications that they also need to be taking at the same time. And although these medications do treat their systemic conditions, it also does play a huge role in patients' oral health and how we can actually treat them. So a typical day, I work Monday through Friday from 8 to 5 p.m. Usually we see 5 to 8 patients a day. I put a question mark at 5 p.m. because sometimes we stay later. The latest I've stayed is till 7 to do clinic notes. And we also have OR every Wednesday, and we start at 6:30 a.m. Just because a lot of these patients, when you go under general anesthesia, you're not allowed to let them eat. Having them eat is an aspiration risk. If they vomit, then it can go in their airway, and that's really bad. And generally on these days, we will see around 1 to 2 cases for complete oral rehabilitation. And what that means is, because we cannot usually look in their mouths in a regular dental clinic setting, we will do a whole clinic exam, radiographic exam, full mouth cleaning, and all treatment that day. What we do in there for fillings is we will do regular small to medium-sized fillings, and any extractions that are needed. Unfortunately, we can't do any endodontic treatment or other perio surgeries or make crowns or dentures, because those are multiple appointment treatments, and we can't bring the patients into the OR as often, and that's not safe for them. As part of GPR, we're also on call. Fortunately for me, at Rancho, we're not a trauma center, so I'm not on call 24 hours, and I don't have to go in on weekends. Basically, what we have to do is we're on call 1 month at a time for 2 months total, and we just triage emergencies. So if patients have dental pain or they have dental swelling or any dental complaints, we will decide, if they really need to come in for dental treatment, or if we can just prescribe some medications to help alleviate their symptoms. And we'll also do any hospital inpatient consultations. So what this means is any patients that are currently staying in the hospital for medical treatment, if they have any dental pain, we'll take care of their emergencies like that. Or if those patients need to undergo surgery, prior to intubations, if they have any loose or broken teeth, we just take them into our clinic and extract those, because it's also an aspiration risk. So what kinds of complaints do patients present with normally in our clinic? So our patients are just like any other patient in the general population. They have the same complaints. Like they have cavities, their gums bleed when they're brushing, they want to replace missing teeth, they have sensitivity when they drink cold beverages, they broke their teeth, or their teeth are really yellow. What kinds of procedures do we do? So we'll do everything within our scope if we're comfortable. We have hygiene and recalls. We'll do restorative. So restorative includes any fillings. OS is surgery or tissue biopsies, wisdom teeth removal, implant placements, endo, root canal treatment, prosthodontics, that includes any crowns or bridges that we need, any dentures that we need to make for the patient to replace missing teeth, perio, and pediatric dentistry. For our pediatric population, it's different. Generally, when we think about pediatric, we think about patients generally just between the ages of, 0 to 18. But in our clinic, because a lot of our patients have neurodevelopmental disabilities, their mental age may be different from their chronological age, and patient management, such as TELSHO do, and due to their limited cooperativity, we have to treat them like we're managing essentially a child. So that's what we consider our pediatric population. And generally for our patients, we are concerned less about cosmetics and more about functionality, just because of their medical conditions. What we consider as ideal treatment for other people like me or you is not necessarily ideal treatment for them. For cosmetics, generally, if you want to replace missing teeth, ideally we would place implants or give you dentures. But for a lot of these patients, if they have seizures or just cannot tolerate anything in their mouth, we wouldn't fabricate those for them. And I generally don't like saying or advertising that, what we do is cosmetic dentistry or anything like that, because I believe that in dentistry, it's inherently cosmetic. You don't go in doing dentistry wanting it to look bad. It's supposed to look good. So some dental instruments or equipment that we generally use in our clinic that you may not necessarily see in a regular private practice are a papoose. So that is this equipment right here. It's basically a board and we strap patients to it. So usually it's pediatric patients or patients that don't cooperate. It's essentially a straitjacket. So it's protective stabilization to prevent patients from hurting themselves and hurting us. So it's beneficial for both parties. Bite stick is this thing right here. Sometimes patients have difficulty opening their mouths or they don't want to open their mouths. So we'll use this instrument to help keep their mouths open, especially for quick dental examinations. Of course, when we use protective stabilization or these bite sticks, we always have to get consent from patient caregivers because it can potentially cause harm. And caregivers may not like that. And, if you don't explain it to them, they might not understand. We also have a sensory room. So this is generally for patients with autism or those with sensory disorders. If we keep the lights off, we have these lights or some weighted blankets. It really calms them down and enables them to let us do dental work on them. Otherwise, we can't really do anything for them. And this right here is a transfer board. It's for people who are wheelchair dependent. For a lot of our patients, we will try to ask them to transfer into the dental chair from their wheelchair. And some of them will, which is easier for us. So we can actually recline them in the dental chair so we can do dental work. So some of them, they can transfer themselves. So they will just scoot across this board into the chair. We also have a LIKO lift. And this is just a contraption that'll help lift them up from their dental chair if they cannot transfer themselves. And it really helps us a lot. So this is actually a video of how it works. I'm just going to show it to you really quickly. So yeah, this is generally what we do in the clinic, except our lift is different because it's built in. And of course, we're not transferring our patient into bed, we're transferring them into the dental chair. So here we're moving on to my patient case. So because of the nature of our patients and me being employed with LA County, I can't really show you any of our patients' pictures or radiographs, but I can, show you some examples of what we are seeing in this patient and discuss it with you. This is actually the case that I'm using for my exit presentation, which is required for our GPR program. So basically, we start um, a treatment from treatment planning and exam all the way to the end, and we just follow through with their treatment. So I have a patient here who I inherited on September 20th, 2020, who is a 40-year-old female who's ambulatory, speaks English, and lives in a nursing facility and arrives with a support staff or caregiver. So when we are talking about these patient cases, it's important to note whether they're ambulatory or not. So whether they can walk, so with a cane, with a walker, or whether they're wheelchair dependent, so it can let us know whether the patient is able to transfer the dental chair or if they cannot, because this really affects our operator positioning and how we are able to provide dental treatment. Usually, if it's a wheelchair dependent patient and they don't transfer, it's really painful for us, especially if we're working in the upper jaw, because we have to bend our necks and our backs to accommodate them. They can't really accommodate us. And that's why if we do have the chance, we'll always encourage patients to transfer to the dental chair, either with a transfer board or a LIKO lift. And we also want to know whether the patient can speak English or any other language, or even if they can speak at all. If they're unable to speak, it is difficult for them to really let us know whether they're in pain or not, or what is bothering them. And knowing what language they speak is very important when we want to obtain informed consent, because we want to make sure that they are understanding what is going on and what kind of dental treatment we're providing them and why we're providing it to them. If patients are living in a nursing facility and needs to come with a caregiver or support staff, we need to ask if they're able to take care of themselves, because this affects their oral hygiene. If their manual dexterity is affected, they can't really brush their own teeth. And generally with those kinds of patients, we will see that they'll have heavier plaque and calculus buildup and gingival inflammation or gum inflammation. We also want to know their chief complaint, which is CC. So this patient's chief complaint was that their tooth hurts. We want to know their chief complaint because we want to know whether we will be able to accomplish what they want us to, and if their expectations of us are manageable and achievable. Often with these more cosmetic cases, if they expect you to make their teeth look like all the teeth that you see on social media, in Hollywood, and their dentition or oral health cannot allow you to achieve that, maybe it's a red flag case and it's better for you to not accept them. And you want to know their medical history and their medications. Like I said before, a lot of our patients are now aging and a lot of them will present with more medical conditions and take more medications. So this particular patient here has diabetes type 2, asthma, schizophrenia, bipolar disorder, and intellectual disability. So for these, we will generally have different treatment modifications. So it will change how you provide dental treatment. For patients with diabetes, we always want to know what their latest A1C is. It's a lab value that lets you know how controlled their diabetes are. So whether they're taking their medications and managing their diabetes well with diet or exercise. It's an A1C is an indicator for 3 months of how well their sugar levels are controlled. You also want to know their blood sugar, because if in the dental setting they are hypoglycemic, they can become unconscious, and that is not a good look for you, you can always have some, a sugar source such as syrup or orange juice on the side in case that happens. For patients with asthma, you want to ask, what triggers them, when was their last attack, if they have ever been hospitalized, and if they have their inhaler with them. So just in case they have an asthma attack in your chair, you are ready to help treat that. A lot of these patients, you'll see that they have long lists of medications, like you see right here. It's very daunting at first, but as you work more with these patients, it's less scary. Eventually, I think for most of the population, you will start seeing that a lot of these patients will be taking multiple medications all at once. And generally what this will do is cause dry mouth. So it does increase a cavity risk. For allergies, this patient's allergic to erythromycin, iodine, and Septra, which is a sulfur drug. So you want to know allergies so you don't give patients medications that will cause them to have allergic reactions, especially when you need to prescribe antibiotics. A lot of patients are allergic to penicillin, so you would want to avoid that. And always you want to associate medications with their medical history, just to be sure that, what they have correlates with what they're taking. Sometimes you'll see redundancies in medications. They're taking multiple medications for a single condition, and maybe that is an indicator that maybe their medical condition isn't as well controlled. Or maybe they're taking a medication that doesn't associate with any medication, medical history, medical condition that you see. So maybe they have something that they're not telling you. So right here, I see benazepril, propranolol. So this patient was taking 2 doses of propranolol, but then that's multiple blood pressure medications, but we don't see that. They had indicated that they have hypertension here. So whenever you're in doubt, consult it out. You can always send out for a medical consultation to confirm with your doctor what medications they have, what they're taking, and what medical conditions they have. If there are any modifications that you have to worry about, just, if you can safely administer lidocaine or use nitrous or perform extractions, whether they have to stop medications before you do some extractions, or whether you have to provide a supplemental dose in case of patients with any adrenal issues, because dental treatment is more stressful for a lot of these people, and that can cause an adverse reaction in your chair. So some oral manifestations of these medical conditions, medications, and habits. Patients who take multiple medications or are older will have dry mouth. So it'll look like this. What happens generally is when you'll know their mouth is really dry, you'll see diminished salivary pool, or when you're using your mouth mirror, it sticks to all of your soft tissue surfaces. Another condition that may cause this is Sjögren's syndrome. So that's basically rheumatoid arthritis. It's an autoimmune disease. It destroys your salivary glands and stops producing saliva for these patients, and that's why it'll also look like this. And when you have less saliva, what happens is your mouth is less likely able to produce a neutralizing effect when after meals and stuff like that. So you'll generally see a lot of cavities or root caries in these patients, especially in older patients when they're more periodontally involved and their roots starts to show because of recession. You'll see a lot more root caries like this. In patients with diabetes or more immunocompromised, you'll see oral candidiasis. And these generally are wipeable. You have to wipe a little bit harder, but if it's only candidiasis, they will come off. It's a differential diagnosis for candidiasis is squamous cell carcinoma. So those are leukoplakia plaques that do not wipe off. And generally for those, you would have to be concerned. You need to correlate that with their social history, whether they smoke or use a lot of alcohol. And generally SSCs will present in the floor of the mouth, on the lateral border of the tongue or tonsil area and soft palate. And loss of posterior support, which is what this patient had a lot of, is missing teeth in the back. So what happens when you miss a lot of back teeth is your bite starts to collapse, so your face starts to look a little scrunched up, and you also don't have a backstop. So your teeth will start to super erupt because there's nothing opposing it, and it may hit the gums. And that just makes your occlusion very unstable. So what you can see with those kind of patients is bruxism or teeth grinding. So you wear down a lot of your front teeth, and that will cause sensitivity. Or when you start to restore their teeth, do fillings for these cavities, they'll tend to fail because bad occlusion will cause your teeth to fracture and fillings to fall out. So generally, when we have these patients after we finish, completing the medical history, reviewing medications, you'll do an extraoral and intraoral exam. So extraoral exam includes checking their TMJ, so palpating their temporal mandibular joints, having them open and close, just like that, seeing if there's any clicking or any deviation of their jaw. If their jaw is limited opening, you'll notice that it'll be more difficult for you to complete dental treatment. So normal range of jaw motion is around 40 millimeters. So that's 4 of your fingers like this. Anything smaller than that, it's going to be difficult to work, especially in the back teeth. You want to see if there's any lesions on their face. If there's any swelling or asymmetry. Swelling may mean they have an infection going on. You also want to palpate their lymph nodes right here just to make sure there's no cancers. So this is also part of your oral cancer screening. So there's posterior auricular lymph nodes here. You just palpate up and down. There's anterior auricular lymph nodes. There's deep cervical. There's lymph nodes here. And then you can move into your intraoral exam. You want to see the condition of their oral health, and you don't want to just look, you want to feel, because you can't always just see what is under the surface. So you want to palpate their soft tissues, like shown in this graphic here. I like to go and feel their gums first, and then lift their lip up here, go into their vestibules. Then I'll look into their buccal mucosa. So I'll pull their lips back with a mirror. And then look on their hard palate, and then tonsil area. So when I look at their tonsil area, I'll have them stick out their tongue. I'll hold their tongue with the gauze so it's not slippery. If they have a lot of saliva, you tell them to say ah, so you can see if their tonsils are swollen or anything like that. And then you'll have them lift their tongue to the roof of their mouth just to make sure, there's no lesions here. Like I explained earlier, that's a common area for oral cancers, and also on the lateral border of the tongue. And generally in dental schools in the US, we use a new universal numbering system. So that is how we will know, which tooth is present and which tooth is not. And that's how we do our dental charting. So because I work in a hospital and our health system is medicine based, we don't really have the typical dental charting system, which is the odontogram, which has teeth for you to note existing restorations or any fillings that they need. But this patient here is missing a lot of teeth, as you can see. Usually we have 32 teeth, 4 of them are wisdom teeth. So usually those are extracted, and that's 1, 16, 17, and 32. This patient's missing a lot. But even on the teeth that she does have that are remaining, have a lot of issues. They have cavities everywhere. So her caries risk assessment is very high. Periodontal charting. So generally we'll do probing depths just to see their periodontal health. So here we see that she has normal pockets of 2 to 3. She doesn't have that much recession or bleeding or furcation involvement. So this patient is more of a caries risk. So she's more prone to cavity. She's not really a perio patient that we know so far. Okay. So after that, we always perform a clinical exam before we do any x-rays, just so we don't have to expose patients to unnecessary radiation. Generally, when we take radiographic exam, especially at the initial appointment, we'll do a FMX or full mouth series, and that typically includes 4 bite wings and then maybe 16 PAs, so we can capture their whole mouth. When we take radiographic exams, this is just to see and confirm our clinical findings. So in her case, we saw multiple carious teeth, carious cavities, grossly carious number 26, which is a lateral lower incisor, but no periapical radiolucencies or bony pathology. So here is a bite wing. Bite wings generally help us diagnose periodontal disease and caries. So this is a normal bite wing. We don't really see any cavities here. Everything is pretty uniform. This is the enamel, dentin, and then pulp chamber. Everything looks fine. Bone levels are good. But here, we see cavities. Cavities generally we'll see between areas of contact, because if people don't floss, that's where food gets trapped and that's where bacteria brews. And here are our periapical radiographs. For this, let me move this right here. They help to allow us to diagnose any periapical pathology. So here, this is a normal periapical radiograph because we don't see any periapical radiolucencies here. We see a strong delineation between alveolar bone and the lamina dura, which is the bone surrounding these teeth. Here we see this is what we call grossly carious or gross caries, because most of the tooth structure is gone. It's a huge cavity. It's extending into the pulp. And usually when that happens, the infection also extends all the way down here. And this is what I mean by periapical radiolucency, because it's less dense than the bone surrounding the tooth. And that just delineates or that indicates infection, and that's when we would go in and do endo treatment. So for this patient, our initial treatment plan, we found that she needs some caries clean out for number 9, 22, 30. Extraction for her grossly carious tooth. Caries clean out is just for teeth that we see huge cavities that may possibly need endo treatment. We don't go straight to endo treatment because we want to make sure that these teeth are savable first before we do that. So what we do is we clean out the entire cavity first, and if we can save the tooth without doing endo treatment, that's great. If not, then we would go in and do that. We always want a consultation with prosthodontics for patients who have loss of posterior support and collapsed bite, because for a lot of these patients with collapsed bite, we need to put a lot of crowns or restoration to help us open that bite. If we don't, we risk having failing restorations and stuff like that. For operative composites, that's just regular fillings for smaller cavities that we can worry about. For fixed, for teeth that, for remaining back teeth that help hold future possible dentures that we make for her in the future, we'll put PFM survey crowns. These are different from regular crowns because they are usually made of metal on the occlusal to help support and retain these removable dentures. And then for maintenance or recall, generally we'll make occlusal guards or night guards for patients that grind their teeth at night just to preserve their dentition, and recall 3 to 4 months for patients who have higher cavities risk, and that is just to have them come in more often for monitoring and cleanings. But for this patient, it was very difficult just because she had so many issues going on. It was like treating a moving target. On October 30th, a month from our initial visit, she fractured her tooth eating peanuts, and so we had to perform a caries clean out and temporize with material called GI. This is a glass ionomer, and it's a material that helps with um, it it releases fluoride. So for patients with high caries risk like this patient, it really helps because it strengthens the enamel. And then on December 4th, she broke another tooth, which is number 9, her front tooth, eating popcorn. So for that tooth, because her pulp was exposed, we just went in and completed a root canal, and then put in a post and core buildup, and then a crown prep um, before we put a crown on it. And the huge issue was this: because of her occlusion and how unstable it was, the provisional crown that we put on her dislodged multiple times, and she had to come in almost weekly to have that replaced. So it was very frustrating both for her and for us. And that is why having a consultation with prosthodontists is very important, just to make sure that these things don't happen. So we did attempt crown deliveries in January, in March, and in April, also because the lab we were working with had some issues making the crown. It didn't fit correctly and her bite kept changing. So for these 2 appointments, we had to alter the crown prep again and remove tooth structure before delivering it um, on April 30th. In January 21st, 2021, we also saw that she broke another tooth, which is really frustrating. Um, just eating hard food, hard crunchy foods again. That tooth we have so far not treated because she's not feeling any pain, and I felt that she had other more pressing needs to address. So from this case, we'll see that education and patient compliance are extremely important. Um, so her case, well, what I learned from her case is always to expect the unexpected. For oral hygiene, we always want to make sure that patients are brushing in a circular motion and flossing in a C shape. For this patient, she did have some kind of plaque and calculus buildup. It wasn't too bad, but her concern was that, she never really had anyone go in and teach her how to floss and brush. And that, I think, goes for a lot of us. Even in dental school, that's one of the first things they teach us. And you'll be surprised at, um, how many people don't know how to actually floss or brush, including me. At first, I didn't know the right way to brush my teeth. I was brushing too hard, going right and left when you're supposed to go in a circular motion. For people with gum inflammation, you can prescribe chlorhexidine gluconate. It's just a mouth rinse that you use 2 times a day. That's what BID means, for 1 week out of each month. That'll help decrease gum inflammation because it's an antimicrobial. It also decreases bleeding. You can also prescribe Prevident 1.1%. It's a fluoride toothpaste. And you want patients to use this nightly after regular brushing, especially for patients with high caries risk. The thing is, if you prescribe these 2 together, you want patients to separate these by 30 minutes, because these actually can cancel each other out if you use them right after the other or use them together. And another huge thing with this patient especially is nutrition counseling. Obviously, we see that what she's been eating really, has been breaking her teeth. She loves drinking soda, eats a lot of candy, eats peanuts and popcorn, and that's why a lot of her teeth are breaking with the soda. That is why we see a lot of root cavities. When you drink soda, a lot of these patients like holding it in their mouth, and that just causes a lot of cavities because especially in patients with their roots already exposed, roots are formed. Their composition is cementum, not enamel. So enamel generally would demineralize at around a pH of 5.5, but cementum and dentin will demineralize at a higher pH. So you want to tell patients to avoid drinking any sodas and avoid any hard, crunchy foods or even sugary foods. And if they have to, have them rinse right after to neutralize the effects of the food. And SDF, so silver diamine fluoride, was super helpful in this case. What silver diamine fluoride is a 38% concentration mixture of fluoride and silver ions. It was initially approved by the FDA for alleviating dentin hypersensitivity. It's minimally invasive and it's very easy to apply. And exhibits an effect called a zombie effect. So what happens is these silver ions kill the bacteria that is found in cavities. But once these bacteria are dead, they act as silver ion reservoirs that continue to release silver ions to help kill other living bacteria that is also found in the caries that are maybe deeper and not more to the surface. And this is very important to obtain a separate consent because of black discoloration. Parents generally will be more hesitant to agree to this if they don't fully understand why we need to do it. This is a temporary measure. We only do this to arrest cavities for patients that generally can't receive traditional restorative treatment. So if patients can't tolerate dental drill, or older patients, it's not very safe for you to administer anesthesia and go in to treat these or extract the teeth, then we will place this on because it stops really fast. It arrests caries, it turns black, and then you can go in later on to do what you need to do. Any contraindications for application of SDF are things such as a silver allergy or carious lesions with pulpal involvement. If the cavity is already so big that you need it's pulpally involved, you should just go ahead and do an endo treatment then and there, because waiting will cause further infection, and you may cause risk of you can cause the spread of infection, and that's pretty bad. If it extends to the point of Ludwig's angina, that can be very life-threatening. That can actually block the patient's airway, so we don't want to do that. And also, it's very painful. And also, you don't want to use it with patients with ulcerative gingival lesions because it's very painful. It's very irritating to the gums. So in the end, I was able to I put SDF on all her teeth just so we can take care of stabilize her oral condition before continuing on with other treatment. I'm still trying to finish her treatment. We need to replace her missing teeth at this point. So hopefully I can finish that before the end of treatment. And then maybe I can even put this on my Instagram account, and then maybe you guys can go see the results and outcome of her dental treatment. So advice to all you future dentists out there: don't be afraid to fail. Failing is the only way that you can learn, and it's better to make more mistakes when you're in dental school than when you're in private practice, so you can avoid making those mistakes. Don't compare yourself to others. In dental school, I felt the need to always compare myself to others. It's very discouraging when you see someone else succeeding more than you are. Maybe they're better than you at studying, or they're better than you at clinical work, but everyone is on their own dental journey. And in the end, you'll all become dentists. So it really doesn't matter. You should just worry about improving yourself, and don't neglect your health. Going into the dental profession is very taxing, both physically and mentally. So really don't skip meals, especially in dental school. I know a lot of us generally neglect that and put our studies first. And don't forget to work out. Honestly, you need a really strong core, because working on patients, you're constantly crouched over them all day. It's really painful for your neck and your back. And especially in a GPR, when you're working on special patients and on patients with disabilities that they can't transfer the dental chair, and you have to cater to their positioning. But do ask lots of questions. Don't be afraid to ask for help. There's no such thing as a dumb question. Take advantage of free CEs while you can. Some websites that I found helpful CEs on are dentalcare.com and even Colgate. They have really good ones. Once you get out of school, CEs are really expensive. They could range anywhere from hundreds of dollars to thousands of dollars. So I think free CEs will really be helpful for you. And do shadow different dentists and specialists even while in dental school. Even now, I've been shadowing multiple specialists, and I found that it's been really helpful, especially for someone who has doesn't have anyone else in the family who is a dentist and who wants to start their own practice. Shadowing these other dentists, you'll learn different techniques that you may want to incorporate that is going to be helpful for you, or even learn about different ways to manage the practice, and even how they manage or communicate with patients, because that is one thing that dental school doesn't really teach you, is managing and communication, patient communication. And that is actually something you have to pick up yourself while you start practicing. And this book right here, I'm obviously not sponsored by them, but I thought it was really helpful in my studies and working with this patient population. If any of you want to learn more or expand on what you learned today, this book really helps talk about what to do and any treatment modifications for patients with any range of medical conditions. So thank you for listening to my presentation. I hope you learned something, if anything at all today, and I appreciate your time. And now if you have any questions, I can answer them to the best of my ability.
Yeah, thank you so much, Doctor. That was very informative, and I'm sure the viewers really enjoyed, the cases you showed and everything, you talked about.
Mm-hmm.
So yeah, so we're gonna go over a couple questions right now, if that's okay with you, and then yeah, we should be good to go. So the first question is, someone in the chat said, USC is my dream school, but I have friends that do not care for the PBL curriculum. How do you feel about this?
I actually get that question a lot. I think it's very case to case, depending on your learning style. For me, I was a more independent learner, so PBL really worked for me. PBL, if you don't know, is a small group discussion, so we don't really have lectures. We learn based off of patient cases. And for me personally, I thought it was better because what we took out of it is basically we had to pull out the case what we thought we needed to know. And I felt that it was a more, it was a way to learn that helped material stick in my mind better, because we're interacting and we're discussing with each other rather than sitting in the lecture hall, having someone lecture to us, maybe falling asleep. I like the more interactive aspect of PBL, but of course it's not for everyone. And it did take some getting used to during first year, because I had never had any kind of teaching experience like that before. But I think it really helps develop your critical thinking. It really makes you more resourceful as a person. It makes you go search for answers, whether rather than having someone, just regurgitate information back to you. So I think I personally liked it a lot. But obviously, that's just me, and a lot of other people in my class may say differently. I don't know if that answers your question.
Okay, perfect. The next person said, do you often use silver diamine fluoride as a less invasive treatment, even though it's not as quote unquote cosmetic?
It depends on the patient population. For patients who are more medically compromised, or in pediatric patients who are uncooperative or can't necessarily, more uncooperative and can't, or have, like my patient's case, has so much going on in their mouth that you need something quick to stop their cavities right then and there, then I will use it, but only as a temporary measure. Obviously, patients don't like that, it turns their teeth black. But if you explain to them that it's temporary, it's just to stop the cavity, and at a later date you'll go in and drill out the black color and fill it in with a tooth colored filling like composite or a glass ionomer, I think more patients are amenable to that. But it's a really great material to use, especially in areas that are more underserved in community clinics, where you see more rampant caries.
Okay, perfect. Now, the next person said, what do cavities look like on radiographs? They weren't able to actually see them on the slide, so they want some, input on that.
Okay, sorry about that. Maybe my graphics are too small. So here, right here, is a normal radiograph. So what you see is everything is more uniform. You don't see any shadowing here. This is enamel, and this is dentin, this is pulp. Right here, we see some darkened areas right here. So that's some radiolucencies. And this is a radiopacity. So the difference between these two is this is darker and this is brighter. So it's radiolucent because there's less structure there for x-rays to go through, and that's why it's darker. So this is what cavities look like as compared to that, right? This is darker here, and usually cavities are more like a triangle shape because that's how they spread. This is a filling, so it's more radiopaque because it's denser than the tooth, so it's more difficult for x-rays to go through, and that's why it appears brighter here.
All right, sounds good. Another question we have is, they're wondering if you could talk about the application and DAT tips.
Dental school applications?
Yeah, dental school application.
What, I don't, it's kind of general. What aspect of application?
Just like, if you can like, give tips about like, let's say personal statement, just like specific aspects like that, as well as just general DAT tips.
Well, I took the DAT a while back, so I think they changed the format a little bit, but I always recommend studying earlier and looking for, remembered questions, because sometimes they'll show up on the exam. Taking a lot of practice tests. I used Crack DAT and DAT Bootcamp, and I thought DAT Bootcamp was very representative of what was on the exam for me. Crack DAT I thought was harder, a lot harder than it had to be, especially for the PAT portion. But taking the exam, it was not as bad as I thought. And I would recommend DAT Bootcamp over a lot of the other prep programs. As for applications, I would encourage you to apply early. A lot of dental schools work by rolling interviews, so they'll offer interviews sooner if you submit your apps sooner. You obviously want really good letters of rec, so building that really good relationship with your faculty and even a dentist, because I think you still need a letter of rec from a dentist to apply for dental school. And you can get those from, networking, or even building the relationship while you shadow dentists. So try to shadow as many specialists and general dentists as you can. That will be helpful on your application. They like that you're well-rounded as well. So a lot of community service, because dentistry is essentially service industry. And if you have a wide variety of interests, you're open-minded to learning new things, I think schools really like that as well. But yeah, I can't emphasize enough to shadow as many dentists as you can. It'll help you in dental school, maybe make things easier for you. So maybe you can apply for an assisting job or work in a dental lab. A lot of my classmates that worked in a dental lab or did some dental assisting definitely had an easier time when we were starting out in clinic, because they had already seen many of these procedures or done them before. And it also helps in, if you want to eventually start your own practice, because it gives you some ideas of how you should go about running an office, maybe how many operatories you want, how you want to spend your time between working between all the patients, how you manage your office staff, and who you want to hire and stuff like that.
Yeah, perfect. I think that was the response they were looking for. You gave, a good answer to that. Now, another question we have is, when you are done with your GPR, what are your goals for your future as a dentist?
Well, I hope to continue to be able to treat this patient population, just because they're so underserved and there's such a great need and there's limited access. I didn't tell you this earlier before, but for our OR patients, the wait list is 1 to 2 years long. So a lot of these patients wait a long time just to receive dental treatment, because regular dentists cannot see them in their regular private practice. And many of them just aren't comfortable working on these patients because of their medical conditions. So I'm hoping I can bring my experience into private practice and eventually bring my own patients into OR and see them there with my hospital privileges. But yeah, I eventually hope to own my own practice. So I have, more freedom to do what I would like to do. I know a lot of people that start out straight from dental school. Dental school will go into corporate dentistry, working for Western Dental or Pacific Dental Services, which is good. But I do like that level of freedom that you get from owning your own practice, because you decide what you want and what you want to do. But with that being said, even for many GPRs, I know with my GPR, many people eventually go on to apply to endo programs or pediatric programs and oral surgery programs, because that is what we get a lot of experience of. And that's, the most apparent next step after finishing GPR.
Perfect. Yeah, thank you. Now, another question we have is, where do you see technology in dentistry in the next 5 years?
In the next 5 years, we'll definitely see more of digital dentistry. Even at USC, we started incorporating a lot of CAD/CAM, which is same day milling for a lot of crowns or onlays, and it's a lot faster. Patients like it. It's very aesthetic as well. We also started doing 3D printed dentures and CAD/CAM dentures. Not many private practices right now currently do 3D printed dentures, just because it's still very new. And even my own experience at USC with these digital dentures is that they break pretty easily. But I think that in the future that will change a lot, just because dentistry advances so fast. There's always new technology coming out. Even now, more and more people are using less alginate impressions and going for intraoral scanning. So you have digital files for that. So I think it's all really exciting, but it's always important to have the fundamentals and understanding to complete conventional dentistry, and then add to that, repertoire with digital dentistry.
Yeah, very interesting intake. Another question we have is, what are your thoughts on starting a new practice from scratch or purchasing an existing one? What are the pros and cons that you think are?
For starting a new practice from scratch, I think that is more difficult, just because you don't have a patient base. And if you're, a new dentist, not many people will trust you. Not many people will know about you. So you will have to do a lot of networking. And what that may entail is driving around and passing out business cards, asking different specialists or stuff like that, maybe talking with them over a cup of coffee, and building an office from scratch. I think costs are a lot higher. You also have to find the perfect office staff. A lot of what goes into running a good practice is having a really good office manager. They're usually the ones that patients see first. They'll answer phone calls for you as well. What's easier about buying a practice is you already have an established patient base. And maybe, you're associating with that dentist already. So a lot of the patients know you. So they're familiar with you and your work and they trust you. But even then, if you're buying off someone and you've never worked with them before, a lot of that patient population may leave your practice and follow that other dentist elsewhere. But I think regardless of what you plan to do, I think both are achievable. It all depends on really what you want to do. Even when you are buying a practice off someone else, I think what you need to keep in mind is, do you like the location? Does the building have a lease? Because just because that, let's say the tenant of that building signs a contract with the landlord, that contract is between the landlord and the tenant, not between you and that landlord. So that contract may change between you. So you can't take that for granted. A lot of the time you'll see that when these dentists buy the practice, then they'll lose that lease because that's not the same contract that the landlord was willing to agree to. Also, what you buy with the practice, also all the dental materials, is that what you really want to work with? A lot of the new dentists that are coming out of dental school want, the fancier machines, CBCTs, CAD/CAM, panels, intraoral scanners, but a lot of the older offices that may be selling don't have those things. But that is an extra cost that you may have to worry about.
So unfortunately, it
totally.
looks like that's all the time that we have for today's session. Sorry, Ibrahim.
No
Thank you
worries.
so much, Dr. Isabel, for joining. That was a very insightful and informative session. And I want to thank all our viewers for joining today's session as well. If you guys have any questions, please make sure to check out Dr. Isabel. Her Instagram can be found on our Instagram page or through the PowerPoint. But yeah, if you guys are looking for the quiz, that can be found on our Linktree or our GroupMe. But once again, thank you guys for joining. We really appreciate it. Thank you, Dr. Isabel, and I hope you all have a great rest of your night. Thank you once again.